right? Okay, well, I need the gizmo. So by now you should all know that what Health for a Better World is, right? Every time you have a cup of coffee. So Providence St. Joseph Health's vision, Health for a Better World, which for me, this really resonated. It felt like this is why I went into healthcare, this is why I became a nurse. It's about improving people's conditions, their health. So Providence St. Joseph, we're on a journey. And none of these headlines or trends are probably surprising to any of you. We've all been, kind of inundated with the news about, I kind of look at these and think this shows corporate America's dissatisfaction with the healthcare system the way it currently exists. Whether it's Amazon, CVS, and certainly the payers are in the mix. They're merging, they're buying, they're selling. Oh, hey, Megan, welcome back. In our own community, we have seen the Everett Clinic become DaVita, and they're going to become Optum. We've seen Multi-Care bring Indigo clinics into Snohomish County, which there is probably a bigger strategy. It's just not visible to me yet, but I'm sure it will reveal itself. Kaiser and their purchase of Group Health. We know they're expanding near the Everett Clinic up at Smoky Point. They're building a new clinic. So things are changing, and it's really nice to think they're changing everywhere else. The fact is, they're changing in Snohomish County. So these are just a few of our current challenges. And again, these are things you've heard someone in the front of this room or on TV or in a video clip from the system. So none of these are big surprises to you, but just to remind you, so the payer mix is challenging. Now mind you, an interesting thing that I think I've watched this year is we're seeing more of a flip from commercial to Medicare. So think about the aging, the needs of the world, So we still are about 68% government payer. We've talked about the need to get to Medicare rates. We're still running at about 125% of Medicare on our expense structure here in Everett. So that continues to be a challenge. There's reimbursement pressures. The commercial payers have said, we're done paying for the gap that healthcare providers have had for years as they've looked at how we've covered the cost of Medicaid and Medicare. And they've said, what's good for government's good for us. So we're seeing declining reimbursement. Certainly the regulatory risk, that's the other fascinating thing. Decreased reimbursement, more regulation. Certainly the Attorney General here in Washington, they're looking at charity care and filing suit, and then, was it Modern Health where Providence is being sued? By CMS? No, by a company that goes out and looks for people who violate CMS billing regulations. So, lots of things happening on the regulatory side that essentially drive up the cost of healthcare, right? Rapid input cost growth. So what's that mean? That means pharmaceuticals. Where's Eric? There's Tom.
PTO.
Oh, he's on PTO, good for him. How much, cost in pharmacy, when you think about the shortages, how much has that driven our purchasing cost? Any guesstimate?
It's probably the main driver of our cost is shortages.
And how much have we gone up just in the last couple of years?
Well, we've been fighting it. We've been pretty good for the most part, but that fills our 10% kind of bumps we get each year.
10% a year, and many organizations saw a 20 or 30% bump last year. We have incredible pharmacy leadership who's just kind of all over this, but between shortages, well, as you said, primarily shortages, and then variation. So many of you are beginning to see the VOA data, and I think it's easy for folks maybe in PMG to think, oh yeah, that's hospital. The fact is, many of these patients are PMG patients, or they're having surgery by PMG, and many of the inputs into our cost are because we've not managed well on the outpatient side, or the patient wasn't prepared. So hopefully we will see the surgical home make an impact in the cost of our surgical patients. Because primarily today, we're getting better and better data around the cost for our surgeries. Hopefully by next year, we'll see more on the medical side, but right now it's primarily surgical. It's a little bit easier to quantify. Looking at complications is a little bit easier. So many of the medical patients already come in with a long list of problems that it makes it a little more challenging. And here's the thing that I think, as we think about how we think and act differently, here's a challenge that everybody that you guys report to is going to get from me. When we come in and we describe, we're going to move this program to Colby, or we're going to grow a program in the Pavilion or at Pacific, I'm going to ask, is that what the patient wants? Where do your patients live? Coming to Colby is a nightmare if you're coming here in January. You can't find a parking place. You can't find your way around. Is that the right thing for the patient? So we need to begin to think, as a patient would think, about where they want their services. And this slide, I really kind of like this slide too. So, Health Point 1 over here, I have to say, when I went into healthcare, so no offense to the ambulatory clinics, I thought the hospital was the center of the world. I loved being there. It's where everything I thought that was exciting or important for patients happened. And then you kind of come to the realization of, oh my gosh, this is 3 days in this person's entire life. So not so much, right? And gosh, probably 10 or 12 years ago, we adopted patient family-centered care as our care philosophy. And that's kind of the middle slide. Hopefully we're better at that. But the third graphic is really, how do we enable our patients? And I've heard Aaron Martin speak a couple of times, and he leads the digital transformation maybe division. Oh, thank you. Digital Innovation. DI, the Digital Innovation Group. So, and Aaron came from Amazon, and so he at a meeting not very long ago, he was telling a story about working with some digital designers on what a screen should look like to be able to schedule your appointment from your phone. And they had this real nice screen flow, and the schedule was in the click was in the lower right corner. And he said, no, it's got to be in the upper right corner. Amazon has trained everybody in the world that when you're ready to buy, it's the upper right corner. And so thinking about how that might translate to healthcare, what is it that our patients want, not what we want, not what makes us efficient. I heard a provider, very well intended, when a patient was telling a story about what a great experience they had at an express care clinic. And he said, but that just, that hurts your primary care provider. They want that relationship with you. And I kind of had this little, oh, well that's fascinating, because really this is supposed to be about what the patient wants, right? Not about what we want. So I think much of this is when you think about the generations coming up, I mean, right? I mean, I'm older, I'm totally good going to the doctor's office. That's kind of what I've been doing for really a long time. But younger folks, they want to be digitally connected. They want to see the doctor while they're on the bus heading to work. And so that's where you're seeing a lot of efforts as far as Express Care or Express Care Virtual. But it's not just when they see somebody, it really is how do we stay connected to our patients and our communities even when they're not coming to our doors. And so we've spent time talking and putting together action plans around the Circle app. Because the Circle app is a great way to connect first with moms, people who are pregnant, so moms and dads, but it's really about, you know, kind of the pregnancy experience. But then parents, because it's now expanded into pediatrics. And so connecting folks to us virtually is where we need to go. We haven't seen a lot of uptake from that, and I've been a little surprised, so I'm not sure if we just haven't convinced ourselves yet that this is the way of the future, but it is definitely part of our strategy. And it is how we are thinking about getting to a future state. Johnny Cox, which some of you may know, he's one of our 5 juridic persons, kind of the lay people that lead Providence, but he was a nurse first and an ethicist, and he worked at Sacred Heart, and he worked for one of the other Catholic systems in California. And he did a presentation, some of the directors were present for this, but he did a presentation in Spokane where a few of us were present. And he reminded us the mission is not the building, right? The mission is what and how we serve our community. So hanging on to physical space, hanging on to a building and believing that's the mission, we have to start to rethink that. We have to be expansive. We have to get outside the box, literally. We have to meet patients where they are. I'm looking at my notes because I don't want to forget anything, and I actually wrote notes on my slides. So, some of the things too that when we think about serving patients. And I think it kind of goes to being our community's health partner, transformation, and strengthening the core is to really think about the work that we do and to try to understand if there's a way to do it differently that doesn't require a hospital. So, you know, how are we partnering with home care? Are there some patients, now mind you, we have a whole lot of long length of stay patients who don't require hospital. That's one issue. But we also have patients who come in because they have pneumonia. Could they get some of their care as an outpatient or some of their care at home with the appropriate monitoring? Granted, there are some that don't have great living conditions, the hospital is the right spot, but are there others that would be suitable for us to think differently about how we deliver it and have it be less expensive and take fewer hospital beds? The hospital is where the cost is. So just some of those things as we start to try to think differently. We do have the 3 strategic areas. These are not new to you. Strengthening the core, community's health partner, and transforming our future. We will be, again, refreshing our strategic plan for 2019. So be thinking about things that might kind of get your juices flowing on things that we should be trying. And strengthening the core, which you know is really our infection rates and looking at how we care for patients in our traditional way. And how do we do it in a way that delivers the very best outcomes for those patients. Community health partners, there's a fair number of partnerships that we are engaged in. For example, physical therapy, outpatient physical therapy will be moving, I'm not sure we have a signed contract, but it's going to be moving to the new Y. That is a much easier place for folks to get access to. It might help our commercial volumes, hopefully. And it's a great partnership. Hopefully individuals will think, wow, this was a really great place to work out. I should join the Y, and then they will be healthier too. So, the gospel mission. The gospel mission is currently in fundraising mode. If you are so inclined, they are looking to raise about $600,000, and they will be building out 16 male respite beds on the second floor of the men's mission. They hope to be ready to accept patients in early spring. So they have been committed to a respite model for probably a couple of years, and they felt like they needed a new building. And one of the ER doctors, because she said, oh, no, we're gonna do this, and he said, why are you waiting? Why can't you do it now? And she had some really good reasons that she's shared with Julie and I a number of times, and he got her over the hump. She kind of went, all right, you're right. There are people who need our help now, so why are we waiting? So hopefully that too, or that will be in the spring. So, looking outside our walls, we don't have to do everything. Who can partner with us? And then transformation. A lot of this work's being done at the system, but I think this is really where the CTC has come into play and where we all need to start to think incredibly differently on how we deliver the services we deliver so we can get our costs down. So there are, So obviously, maybe not obviously, but we are guided by the mission. We have a restatement of the mission. The mission hasn't changed. Again, I love the vision, health for a better world. And these are the four things. We're looking at strengthening the core, community's health partner, and transforming. And there are really three bodies of work that are going to be done, that are in process actually. Revenue growth. So some of it has to do with us, much of it doesn't have to do with us. Much of the work we are doing is currently being kind of framed as modernization. So we are looking at, primarily things away from the bedside, but we are looking at the systems and structures that support the work that we do. And when I say we, I mean this is at the system level, and figuring out how to do it less expensively, more affordably. So looking at revenue cycle optimization, payer contracting, how do we grow our commercial volume? We aren't saying we don't want to care for Medicaid, Medicare, uninsured. But in order to do that and do it well, we need to grow commercial. Diversification in ambulatory. A new division has been created in Providence St. Joseph Health called the ambulatory division. This is not our ambulatory clinics. This division will be ambulatory surgery centers, possibly, nobody get all worried, walk-ins, urgent cares, express cares. So we do expect that express care will move to a system reporting relationship mid-year sometime. That doesn't mean we will have any different relationships. It's kind of like home care. They're Providence, they're here in Snohomish County, and we work with them and we refer patients back and forth. So it's not going to change any of that, but there's also a possibility for GI suites, which of course we don't own an outpatient, an ambulatory GI suite. So right now, ambulatory is really a huge focus. We know that's where much of the healthcare for our community is going to be delivered. And so how do we get a little more aggressive and active in that space? And then population health. We had, when Christy was here, Christy Putnam, we had a pretty aggressive plan. That's kind of slipped away as the ACO went through a bunch of changes. We definitely are engaged in the ACH, the Accountable Communities for Health, but we have to get what Mitesh and I and a number of others, we're in pretty regular conversation about how do we re-energize population health and get really focused on that. And then we've got the digital solutions and, oh boy, Exnovate. Is there a talking point here for me on Exnovate? It's kind of like innovate, but I think it's doing it and selling it or doing it in partnership. So that is one of the things is that as we think about a lot of our technology and digital, for example, the Circle app, Providence has sold majority ownership or all of it to another vendor. So we are developing things and we are selling things. And there are important times to sell things. This next one is capital efficiency. So reallocating capital, that was kind of the focus on ambulatory that I was talking about. I don't believe that means we won't get our funding for the 9th floor, but there's got to be a really good return on investment in order for the system to want to invest $40 million, particularly in Everett where they just invested, well, you know, starting with the, Scott's over there laughing, starting with the, with actually the cancer partnership, it was $750 million that went into Snohomish County. So, you know, we've got to demonstrate that we can be incredibly cost-effective and return on that investment for them to come and for them to be willing to fund that. Divested non-core assets. So this is kind of one of those touchy ones because the example I'm going to use is PacLab and LabCorp, which the thinking on selling PacLab was that lab services are a commodity. It's something people buy. It's not the healthcare, right? It's not the provider. And when you have an asset, you try to sell it when it's still worth some money. So that, we sold PacLab and are in a new relationship with LabCorp. So I guess what I want you to think about is sometimes what's good for everybody is not always so great for everybody. So this has been hard, and it's hard for all of Washington State. And we will get to a point where we're at a new norm. We just aren't there yet, so you need to continue to raise your concerns, but we also need to appreciate, Scott and I sat in a meeting yesterday, and we went through a list of assets that Northwest Service Area has, and it was like, do you really need to own this? Could we sell it, lease it back? So just a real different look at kind of the things that we own. How am I doing on time? Oh, okay. And then partnerships. So again, there was a time when Providence believed they had to be the majority owner of everything, meaning at least 51%. That's no longer the thinking, just so you know. We will enter partnerships with many. It's going to be important that those partners have the same values and serve the same population that we serve. But with that said, it is no longer necessary for us to be in control of everything. So that's a change you may see. I don't know of anything in Snohomish County, but it sure could happen. Well, here's an example. Rehab. I think Kindred, I don't know what percentage they own, but they're going to be the managing partner of the rehab hospital. So when that actually, when they actually get property, still don't have property, just so you know. And then we've got modernization and functional excellence. This is a place where I believe every one of us is going to be touched. I don't know how, my commitment to you guys is, know something, I will tell you. What I can tell you is currently there is work being done on 49 work streams. I can tell you big buckets, but I can't tell you exactly what that is. We are beginning to see some small changes come forward. One, for example, is I was just notified that the individual who has been our one real estate contact, one of the positions that has served Washington and Montana has been eliminated, and we have a new leader that will be our contact, and the person who was in the job, though, slipped into a position that was vacant, so that's good. But modernization, we have got to get to affordability at Medicare. And I think what we all feel is we have done our darndest here to do that work, to drive down our costs, and yet it feels like we just, I mean, we're kind of treading water because we have salary increases and we lower the cost about that same amount. So in essence, that's pretty darn good work. And I think the system has recognized a lot of this is an overhead. And I don't mean things that are unessential, but really it's how we organize ourselves at a system level. So we are going to become more and more, I believe, an operating company where the care delivery is here, but similar to, I'm looking at Mark in the back, REH, otherwise known as supply chain. That's how anyway, REH, yes, resources.
Engineering, hospitality.
Thank you. Oh, there's Carla. HR, real estate. I think we're going to see more of that where we can be incredibly standard across the system. That will require less resources on an administrative level. So an example, were you working on nursing job descriptions? How many did we have across the system?
I can remember, many, 70 some.
Across the system?
Well, when it got down to me, I know.
4,500.
4,500 RN job descriptions.
Oh, wait, no, you said job descriptions, 4,500, but that's everybody's.
45, okay, let me rephrase that. 4,500 job descriptions. Anyway, point made, right? There are not 4,500 different jobs in every facility. So by standardizing our job descriptions, let's say for an RN or a director or a CEO, it is a ton less administrative management when it comes to everything. When it comes to paying people, when it comes to maintaining the job descriptions, when it comes to MIPs, when it comes to comp. So that means all of the departments that support that work can do it with fewer resources. So much of the standardization is going to be around those kinds of ideas and leadership structures from the system down. And like I said, when I know, I'll tell you. I really don't know much more than what I've just shared. Trying to think if there's anything more about that I should say. I think that we will begin to see changes kind of trickle out. I would be surprised if we don't see the bulk of them before the end of the year, because if in fact we want to drive to a much higher EBITDA in 2019, we've got to make some changes. And I, for one, am really grateful to be working for a large organization. Doesn't mean it's going to be easy, but financially, I've cited this quote way too many times. I hope it's true. So Scott and I were in a meeting on Monday, and a person said that Moody's has predicted or has said that based just on hospitals, EBITDA 10 to 15%, 15 to 20% will close in the next couple of years. So really important to be part of an organization that is forward-thinking enough to say, what do we do to put ourselves in position to be here for another 100 years? So I am really grateful for that. And I think we all are gonna be supporting one another because there's gonna be workflow changes that we all know. We've lived through a number of changes, and you know, whether it was some of the HR work or whatnot, our jobs are gonna be to figure out how to work. It's what we do every day. How do we work with others, right? To get the best outcomes for our staff and for our patients. So other non-negotiables. Other than driving down costs. Are you laughing? Sustain the mission, number one. I mean, that's what this is about, is how do we sustain it? We're all gonna come and go. There are gonna continue to be patients in this community. We wanna make sure that they're getting as good a care 30 years from now as they get today. Caregiver engagement, we know what turnover costs, and we know that when we stir up the folks that report to us, it makes a lot more work for all of you. So ensure patient safety and quality, bend the trend, and meet our budget, which that's gonna be, we've got our work cut out for us, and I know I've said that every year for a while, but really this time. Reinvest in kind of the changes that we're looking at. And we want to be best in class, of course, none of us are competitive. So roles as leaders, we need to continue to challenge ourselves. And when Scott did this slide, it was challenge ourselves to think differently, act differently, and lead differently. And for me, that's one I've spent a lot of time thinking about. What do we as leaders need to do to lead through what's going to be pretty tumultuous, possibly? And what do we do to lead so that the patient doesn't ever experience any of the changes that we might be struggling with as leadership? We've got to create some safe space for all of us to come together, because we don't want our direct care staff wondering about how they're going to get a supply item, or, you know, where the next widget comes from. They've got bigger fish to fry, and it shouldn't be that. So we're working on creating some opportunities as we start to see changes. Like I said, not many yet. No, we're going to need to make hard choices. You know, you've probably heard, does everybody need to do every brand new procedure? Probably not. We want to do it because we love doing new things. But should it be us? Or should it go to Spokane or to Swedish or to Olympia? There's going to be some hard work done in service line groups that we're providing for. We're going to figure out how to make sure you all have a place to come, and we can all work through some of the issues that we might experience. We need to support the work that's going on because it's really for the greater good. It's for preserving the mission. It's for better health for everybody in our communities. So hard, yes. Some of the decisions may not be great for us, but for the greater good. And some may be really awesome for us and others hated. So, you know, we're all in this together. And, I love, remain faithful. So, this really is about responding to the signs of the times, and that's Mother Joseph, correct? Was that Mother Joseph or Mother Gamlin? I'm looking at Barry, he's like, it was one of them. All of the sisters. Okay, there you go. It was an inclusive statement. Deliver excellence, stay sustainable. That really is delivering our mission now and into the future. Focus on the future. That's the thinking and acting differently. Be affordable. Lots of work still to do there. I am excited for you guys to see the insights data, the VOA data. It's very revealing and oftentimes causes us to go, how did that happen? What do you mean? How could that possibly be? And then modernize. And that's really the work of essentially redesigning a lot of the workflows that we're all engaged in every single day.